Good morning friends, welcome to my channel Medics tutorial. This is the sixth video of the urinary system and today's topic is pathology of urinary system. In this section you will learn about the various pathologies of urinary system and their characteristic features which will help you to come with appropriate diagnosis in future. The clinical manifestation of renal diseases can be grouped into reasonably well-defined syndromes, which will we see in next slides. Some are peculiar to the glomerular diseases and others shared by several renal disorders. Casts in urine. Presence of casts indicated that hematuria, loss of blood in urine, or polyuria, excessive urination, is of glomerular or renal tubular origin. Presence of cast indicates it may be a glomerular or a renal tubular origin. Bladder cancer and kidney stones can be associated with hematuria, but no cast. Acute cystitis, it associated with polyuria and no cast. RBC casts, it can be present in glomerulonephritis, hypertensive emergencies. WBC casts, it may be present in tubulointestinal inflammation, acute pyelonephritis, and transplant rejection. Granular cast, acute it presents in acute tubular necrosis, ATN. It can be it have muddy brown appearance, as you can see in this image. It have muddy brown appearance. If it's look like muddy brown, then think about the granular cast, which is present in acute tubular necrosis. Fatty casts, which are oval fat bodies, it's associated with the nephrotic syndrome, as you can see in this image. Its appearance is like a Maltese cross sign. As you can see, it's cross sign. It's look like cross sign, especially a Maltese cross sign. Waxy cast, it indicates a end-stage renal disease or a chronic kidney disease. Hyaline cast, it is non-specific, can be normal finding with dehydration, exercise, or diuretic therapy. Form via solidification of a tam horsefall mucoprotein, which is also known as uromodulin, secreted by renal tubular cells to prevent UTIs. This is the hyaline cast. It shows RBC cast, and this image shows WBC casts. Please do remember all these casts and their appearance as it associated with the diagnosis, as we saw. Nomenclature of the glomerular disorders. First we'll talk about its type, then its characteristic, after that example. First one is the focal. If it's a less than 50% of glomeruli involved, then it's known as focal, and its example is the focal segmental glomerulosclerosis. Diffuse type, if greater than 50% of glomeruli involved, then it's known as the diffuse type of glomerular disorders. Its example is the diffuse proliferative glomerulonephritis. Proliferative, when it's a hypercellular glomeruli, then it's proliferative. Its example is membranoproliferative glomerulonephritis. Membranous, thickening of glomerular basement membrane. Its example is membranous nephropathy. Primary glomerular disease. It is a primary disease of the kidney, specifically impacting the glomeruli. Its example is minimal change disease. Secondary glomerular disease. It is a systemic disease or a disease of another organ system that also impact the glomeruli. Example, UCL or diabetic nephropathy. Now we'll start with the glomerular diseases. It classified into three subclasses. First is the nephritic syndrome. Second is the nephrotic syndrome. Third one is the nephrotic syndrome. Glomerular disease. As we see in earlier slides, there are three types of the glomerular diseases: nephrotic syndrome, and the nephrotic syndrome. In this slide, we'll see its etiology, clinical presentations, and the examples. So first we'll start with the nephrotic syndrome. Its etiology is glomerular inflammation. It is associated with glomerular inflammation, which leads to the glomerular basement membrane damage, which leads to loss of the RBCs into urine, and it appears like dysmorphic RBCs and the hematuria. When patient presents with the dysmorphic RBCs and the hematuria, think about the nephrotic syndrome. Its clinical presentations are hematuria, RBC cast in urine, decreased glomerular filtration rate, which is due to the oliguria and azotemia, increased renin release, hypertension, proteinuria, often in the subnephrotic range, less than 3.5 gram per day, but in severe case, maybe in nephrotic range, it will increase. Its example are infection associated glomerulonephritis, Good-Fasher syndrome, IgA nephropathy, which is also known as Beger disease, Alport syndrome, membranoproliferative glomerulonephritis. Second is the nephrotic syndrome. It is associated with podocyte damage, which impaired carrier charge barrier, which leads to the proteinuria. It is the main finding of the nephrotic syndrome, that's proteinuria. Clinical presentations: massive proteinuria greater than 3.5 gram per day with edema, hypoalbuminemia, which leads to the increased hepatic lipogenesis, which leads to the hypercholesterolemia. Patient also present with a frothy urine with fatty casts associated with a hypercoagulable state due to antithrombin 3 loss in urine and increased risk of infection just because of loss of IgGs in urine and soft tissues compromised by edema. Examples may be primary, example direct podocyte damage, or secondary, it means podocyte damage from systemic process. Focal segmental glomerulosclerosis, it could be primary or secondary. Minimal change disease, it also can be a primary or secondary. Membranous glomerulopathy, primary or secondary. Amyloidosis, it's mainly a secondary, which means podocyte damage from systemic process. Diabetic glomerulonephropathy, which is also secondary. Now, lastly, we'll see the nephrotic syndrome. It is severely associated with the glomerular basement membrane damage, which leads to loss of RBCs into urine, plus impaired charge barrier, which leads to the hematuria and proteinuria. Neph- Nephrotic range proteinuria greater than 3.5 gram per day, and concomitant feature of nephrotic syndrome can occur with any form of nephrotic syndrome, but in most common with diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis. Nephrotic syndrome. First, we'll talk about the nephrotic syndrome, which is associated with the inflammatory process of the glomerulus. Under examples of the nephrotic syndromes are, first one is the infection associated glomerulonephritis, which is also known as post-infectious glomerulonephritis. Type 3 hypersensitivity reaction associated with hypocomplementemia due to consumption in children, most commonly caused by group A streptococcus, post-streptococcal glomerulonephritis. It's seen approximately 2 to 4 weeks after pharyngeal or skin infection. Positive streptococci serologies usually removes spontaneously in adults. In addition to group A streptococcus, can also be caused by staphylococcus seen during infection. Infection site is variable, but usually not upper respiratory tract, must be identified on culture, as no serological test available, may progress to renal insufficiency. On low microscopy, it shows glomeruli enlarged and hypercellular, as shown in diagram A in next slide. Immunofluorescence, it shows granular starry sky appearance and humpy bumpy, as shown in B diagram in next slides, due to the IgG and IgM and C3 deposition along glomerular basement membrane and mesangium. On electron microscopy, it shows subepithelial IC humps. IgA nephropathy or Begus disease. It is an episodic hematuria that usually occurs concurrently with respiratory or GI tract infection. IgA is secreted by mucosal lining. Renal pathology of IgA vasculitis. On low microscopy, it shows mesangial proliferation. On immunofluorescence, it shows IgA based IC deposits in mesangium. On electron microscopy, mesangial IC deposition. Now we'll talk about the rapidly progressive glomerulonephritis or crescentic glomerulonephritis. It has poor prognosis, rapidly deteriorating renal function, days to weeks. On low microscopy, it looks like crescent moon shape. Crescents consist of fibrin and plasma protein, example C3b, with glomerular parietal cells, monocytes, and macrophages. Several disease processes may result in this pattern, which may be delineated with immunofluorescence. linear immunofluorescence due to antibodies to glomerular basement membrane and alveolar basement membrane, which leads to the Goodfather syndrome, hematuria, hemoptysis, type 2 hypersensitivity reaction. Its treatment includes plasmapheresis, negative immunofluorescence, or post-immune. It has no IgC3 deposition, granulomatosis with pharyngitis, PR3, ANCA, eosinophilic granulomatosis with pharyngitis or microscopic polyangiitis. On granular immunofluorescence, it indicates post-streptococcal glomerulonephritis or diffuse proliferative glomerulonephritis. As you can see in this image, it is a low microscopic image of the infection-associated glomerulonephritis, which shows glomeruli enlarged and enlarged and hypercellular. Now, in this image, it is the immunofluorescence of the infection-associated glomerulonephritis. It shows granular. As you can see here, granular starry appearance and bumpy. As you can see, lumps and bumps here due to the deposition of the IgG, IgM, and C3 deposits along the glomerular basement membrane and mesenterium. Now, as I said earlier, in this image, this is the low microscopic image of the rapidly progressive or the crescentic glomerulonephritis. It shows a crescent moon-shaped appearance as it present in a rapidly progressive glomerulonephritis. Diffuse proliferative glomerulonephritis, often due to the SLE, systemic lupus erythematosus. This is like a wild lupus. Diffuse proliferative glomerulonephritis, membranous proliferative glomerulonephritis, often present as nephrotic syndrome and nephritic syndrome concurrently. On low microscopic image, it is like a wide looping of capillaries, as you can see in this image. It's looking like a wide looping of the capillaries, as you can see here. If you see such appearance, it will be diffuse proliferative glomerulonephritis. On immunofluorescence, it looks like a granular. On electron microscopic, subendothelial, sometimes subepithelial or intramembranous IgG based ISCs, often with C3 deposition. Alport syndrome. It is due to the mutation in the type 4 collagen. It leads to the irregular thinning and thickening of and splitting of glomerular basement membrane. It is most commonly X-linked dominant character, which leads to the eye problem. Example: retinopathy, anterior lenticular glomerulonephritis, sensory neural deafness. It can be described as can't see, can't be, can't hear, or be. Means there is an eye problem, glomerulonephritis, and sensory neural deafness. On electron microscopy, it shows basket view appearance due to irregular thickening of the glomerular basement membrane. Membranoproliferative glomerulonephritis. It is a nephrotic syndrome that often co-present with nephrotic syndrome. Type 1 membranoproliferative glomerulonephritis may be secondary to the hepatitis B and C infection, may also be idiopathic. It shows subendothelial IC deposits with granular on immunofluorescence. Type 2 membranoproliferative glomerulonephritis associated with C3 nephritic factors IgG antibodies that stabilizes C3 convertage, which leads to persistent complement activation, which leads to the decreased C3 levels. Intravenous deposits, also called dense deposit disease. Both types, type 1 and type 2, shows mesangial ingrowths, which leads to the glomerular basement membrane splitting, which looks like a tram track as shown in this figure. It's look like a tram track appearance on H and E, that is a hematoxylin and eosin stain, and pus stain, which means periodic acid shift stains. Nephrotic syndrome. It is associated with massive proteinuria that is greater than 3.5 gram per day. Now let's see the examples of the nephrotic syndrome one by one. First one is the minimal change disease, which is also called lipoid nephrosis, most common cause of nephrotic syndrome in children, often primarily associated with idiopathic, also may be triggered by infection, immunization, and immune status, which we can remember it by 4 eyes of MSD. 4 eyes, which is the idiopathic, immune infection, immunization, immune status. Rarely, rarely may be secondary to lymphoma. Example: cytokine-mediated damage. Primary disease has excellent response to glucocorticoids. On light microscope, normal glomeruli are shown. Lipid may be seen in proximal tubular cells. Immunofluorescence are negative. There is nothing abnormal detected. On electron microscopy, infracement of the podocyte food processes are seen. It means the loss of the interdigitation of the podocytes are seen. Focal segmental glomerulosclerosis. It have higher prevalence in black people. It means it mainly is seen in black peoples. It can be primary or secondary. Primary is mainly idiopathic, secondary to other conditions such as HIV infections, sickle cell disease, heroin use, obesity, interferon treatment, or congenital malformations. Primary disease has inconsistent response to steroids. It may progress to the CKD, chronic kidney disease. On light microscopy, segmental sclerosis and hyalinosis are seen. On immunofluorescence, it often negative but may be positive for non-specific focal deposits such as the IgM, C3 and C1. On electron microscopy, it shows infringement of food processes similar to the minimal change disease. Membranous nephropathy, also known as membranous glomerulonephritis, can be positive, can be primary and secondary. Primary to the antibodies to phospholipase A2 receptors, secondary to drugs such as NSAIDs, penicillamine, gold, infections such as HBV, HCV, syphilis, ESLE, or solid tumors. Increased risk for thromboembolism, example DVT, deep vein thrombosis, renal vein thrombosis. Primary primary disease has poor response to steroids, may progress to CKD. On LM, it shows diffuse capillary and GBM thickening. On IF, granular due to immune complex IC deposition. On EM, spike and dome appearance of subendothelial deposits. This is the electron microscopic image of the minimal change disease, and here as you can see it shows the infringement of the podocyte food processes, which means the loss of the interdigitations of the podocytes, as you can see here. This is the light microscopic image of the focal focal segmental glomerulosclerosis, and it shows segmental sclerosis, as you can see here, and hyalinosis. It shows a segmental sclerosis and hyalinosis, which represents the focal segmental glomerulonephritis. This is the light microscopic image of the membranous nephropathy, and it shows the diffuse capillaries, as you can see here, and the glomerular basement membrane thickening, as you can see here. Amyloidosis. Kidney is the most commonly involved organ. Systemic amyloidosis associated with the chronic conditions that predispose to the amyloid depositions. Example AL amyloid, AA amyloid, prolonged dialysis. In ELM, Congo red stain shows apple green birefringence under the polarized light due to the amyloid deposition in the mesangium. Birefringence means the single ray of light bifurcates into two rays under polarized light due to amyloid deposition in the mesangium. Diabetic nephropathy. Diabetic glomerulonephropathy. It is the most common of the ESRD, that is the end-stage renal disease in the US. Hyperglycemia leads to the non-enzymatic glycation in tissue proteins, which leads to the mesangial expansion, glomerular basement membrane thickening, and increase the permeability, hyperfiltration, which leads to the glomerular hypertension and the increased glomerular filtration rate, which leads to a glomerular hypertrophy and glomerular scarring, that is glomerulosclerosis, which leads to the further progression of the neuropathy. On the light microscopy, it shows the mesangial expansion, glomerular basement membrane thickening, and the eosinophilic nodular glomerulo- glomerulosclerosis, also known as the camel's tail Wilson lesions. As you can see here, these are the camel's tail Wilson lesions. Now we'll see kidney stones. It can lead to severe complications such as hydronephrosis, accumulation of fluid inside kidney, pyelonephritis, and acute kidney injury. Obstructed obstructed stone presents with a unilateral flank tenderness, colicky pain leading to groin hematuria. Treat and prevent by encouraging fluid intake. Radioactive radioactive stones found by a cysteine and uric acid. We can remember it by a mnemonic: I can't see you. C for cysteine, U for uric acid. Now, first we'll talk about the calcium stones. It precipitates with the oxalate and phosphate. So first we'll talk about the calcium oxalate stone. Patient those who have calcium oxalate stone, they eventually present with a hypocitraturia, which means the excretion of citrate less than 320 milligram per day. The X-ray finding and the CT findings are same. Both are radiopaque. It's same for the calcium phosphate also. The urine crystals of the calcium oxalate shaped like a envelope or dumbbell. Calcium oxalate stones are most common, approximately 80%. Calcium oxalate stones are more common than calcium phosphate stones. Please do remember, as it's very important. Calcium oxalate stones more common than calcium phosphate stones. Can no. Calcium oxalate stone can result from ethylene glycol ingestion, vitamin C overuse, hypocitraturia associated with decreased urine pH, malabsorption, example Crohn's disease, and its treatment includes thiazides, citrates, low sodium diet. Now we'll talk about the calcium phosphate stones. Those patients who have calcium phosphate stone, there it increase the urine pH. Both X-ray finding and CT findings are radiopaque, and the shape of stones are wedge-shaped prism. Treatment: low sodium diet, thiazide. Ammonium magnesium phosphate stone or struvite stone precipitate with the increased pH of urine. X-ray findings and CT findings are radiopaque. Urine crystals are like coffin lid or sarcophagus. Struvate, sarcophagus, both include yes. So we can remember that struvate stone are like sarcophagus. It accounts approximately 15% of all stone caused by infection with the urease positive bugs. Example: Fructis mirabilis. Staphylococcus saprophyticus, Klebsiella, that hydrolyzes urea to ammonia, which leads to the urine alkalinization, commonly form staghorn caliculi, which form staghorn caliculi. Remember that. Potassium magnesium phosphate or the struvate stone form staghorn caliculi. Its treatment includes eradication of the underlying infection with the antibiotics and surgical removal of the stone. In this image, we can see that the stones are like envelope or dumbbell shape. So we can say that it is the calcium oxalate stone. In this image, we can see the stones are coffin lid like shaped or a sarcophagus like shaped, which is only present in a ammonium magnesium phosphate stone, or also known as a struvate stone. S for struvate, S for sarcophagus. As we can see in this image, it's a staghorn caliculi. This is the staghorn caliculi, which is made up of the ammonium magnesium phosphate stone or struvate stone. Now we'll talk about the uric acid and cysteine, which both form radiolucent stones. Also, we can remember this by a mnemonic: I can't see you, C for cysteine, and U for uric acid, which form radiolucent stones. Now we'll talk about the uric acid. The precipitate with a decreased pH level of pH of the urine. X-ray findings are radiolucent and CT findings are visible. The shape of uric acid crystals are rhomboid or roseate, as you can see in this image. It's look like rhomboid or roseate. About it accounts about 5% of all stones. The risk factors to develop a uric acid stones are decreased urine volume, arid climate, and acidic pH. Strong association with the hyperuricemia. Strong association with the hyperuricemia. Example: gout, often seen in disease with the increased cell turnover. Example: leukemia. Treatment: alkalinization of the urine and allopurinol. Treatment includes alkalinization of the urine and allopurinol. Cystine stone. It is precipitated with a low pH urine. X-ray findings are faintly radiopaque. CT findings are moderately radiopaque, and its shape are hexagonal. As you can see in this image, it's a hexagonal shape stone, and it is a hereditary autosomal recessive condition in which cystine reabsorbing PCT transporter loses function, causing cystinuria. Transporter defect also result in poor reabsorption of the ornithine, lysine, arginine. So the cystine stones can be caused due to the poor absorption of the cystine, ornithine, lysine, and arginine. We can remember it by mnemonic COLA: C for cystine, O for ornithine, L for lysine, and A for arginine. This forms cystine stones. Cystine is poorly soluble. The stone form in urine. That's Cystine is poorly soluble in purely soluble. That's why stones form in the urine usually begin in childhood, can form staghorn calciculi as like ammonium magnesium phosphate stones. It also forms staghorn like calculi. Sodium cyanide nitroprusside test positive. The sodium cyanide nitroprusside test was positive. Also, we can say that 16 stones have 6 sides, means 16 for 16 stones have 6 sides for hexagonal shape. Treatment includes low sodium diet, alkalinization of urine, chelating agents such as thiopronine, penicillamine if refractory. Hydronephrosis, which means the accumulation of fluid inside a kidney, distension or dilation of renal pelvis or the calyxes, usually caused by urinary tract obstruction. Example: renal stones, severe benign prostatic hyperplasia, congenital obstructions, locally advanced cervical cancer, or injury to ureters. Other causes include retroperitoneal fibrosis, vesicoureteral reflux. Dilation occurs proximal to site of pathology. It means if here is the obstruction, here will be distension or accumulation of the fluid. Serum Serum creatinine level becomes elevated if obstruction is bilateral or if patient has an obstructed solitary kidney. Leads to compression and possibly atrophy of renal cortex and medulla. Acute cystitis, inflammation of the urinary bladder, presents as suprapubic pain, dysuria, painful urination, urinary frequency, urgency. Systemic signs, example, high fever, chills are usually absent. Risk factors include female sex as they have shorter urethra, sexual intercourse, indwelling catheter, diabetes mellitus, impaired bladder emptying. Causes includes E. coli, which is the most common, Staphylococcus saprophyticus, seen in sexually active young women. E. coli is still more common in this group. Klebsiella and Proteus mirabilis. Urine has urine has ammonia scent. Laboratory findings include positive leukocyte esterase, positive nitrites indicates presence of the Enterobacteriaceae, sterile polyuria with negative urine cultures could suggest urethritis by Neisseria gonorrhoeae or Chlamydia trachomatis. Treatment includes antibiotics such as trimethoprim sulfamethoxazone or nitrofurantoin. Urinary inconsistence. So there is a problem with the urination. Mixed inconsistence has features of both stress and urgency inconsistence. First we'll talk about the stress inconsistence. As you can see in this image, there is a pressure applied on the upper side of the bladder. That's why there is a leaking of the urine. So its mechanism is outlet incompetence, urethral hypermobility, or intrinsic sphincter deficiency, which leads to the leak with increased leak of urine with increase intra-abdominal pressure like as sneezing, lifting, coughing. It shows a positive bladder stress test directly observed leakage from urethra upon coughing or Valsalva manual. Its associations are obesity, pregnancy, vaginal delivery, prostate surgery. Its treatment include pelvic floor muscle strengthening, which is also known as Kegel exercises, weight loss, and pessaries. As you can see in this image, the detrusor muscles are overly active. That's when detrusor muscles are contract and the urine is leaking out. Mechanism: detrusor muscles overactivity, which leads to the leak with urge to void immediately. It's associated with UTIs, urinary tract infection. Its treatment includes Kegel exercises, bladder training, time voiding, distraction or relaxation techniques, antimuscarinics, antimuscarinics, which includes oxybutynin or overactive bladder, mirabegron. We can give antimuscarinics. Example: oxybutynin for overactive bladders and mirabegron. As you can see in this image, the bladder is underly active. That's why the detrusor muscles are relaxed and it is unable to emptying bladder. So incomplete emptying, detrusor muscle underactivity or outlet obstruction leads to leak with the overfilling, which increase post-void residual on catheterization or ultrasound. Its association are polyuria, example diabetes, bladder outlet obstructions, example benign prostatic hyperplasia, or and spinal cord injury. Its treatment include catheterization, really obstruction by giving alpha blockers for BPH. Pyelonephritis, which is the infection of the kidney. Now we'll talk about the acute pyelonephritis. It, it shows the neutrophil infiltrate renal interstitium, affects cortex with relative sparing of glomerular or vessels, presents with a fever, flank pain, costovertebral angle tenderness, nausea, vomiting, and chills. Causes includes ascending UTI. E. coli is the most common. Hematogenous spread to kidney, present with a WBC in urine or positive negative WBC cast. CT scan of kidney shows striate parenchymal enhancement. As you can see in this image, it shows a striated parenchymal enhancement on the CT, and in this image we can see the neutrophil infil neutrophil infiltrate in interstitium of the kidney. As you can see, these are the infiltrates, neutrophil in interstitium. Risk factors include indwelling urinary catheter, urinary tract obstruction, vesicoureteral reflux, diabetes mellitus, pregnancy, progesterone mediated low in urine tone, and compression by gravid uterus. Complications include chronic pyelonephritis, and renal papillary necrosis, perinephric abscess with a possible posterior spread to adjacent source muscle, urosepsis. Treatment includes antibiotics. Chronic pyelonephritis, the result of recurrent or inadequately treated episodes of acute pyelonephritis, typically requires predisposition to infection such as vesico-irritable reflux or chronically obstructing kidney stones. Cause asymmetric corticomedullary scarring, blunted calyxes. Tubules can contain eosinophilic cast resembling like a thyroid tissues, which is also known as thyroidization of the kidneys. As we can see in this image, it's look like a thyroid tissue, which is a follicle that's known as the thyroidization of the kidneys in the chronic pyelonephritis. Now, there is one more complications, which is the xanthogranulomatous pyelonephritis. It is a rare, grossly orange tubules that can mimic tumor nodules, characterized by widespread kidney damage due to granulomatous tissue containing foamy macrophages associated with protease infections. Acute kidney injury. There are three types of kidney injuries. First one is the prerenal azotemia, intrinsic renal failure, and the postrenal azotemia. We'll see etiology, pathophysiology, and the laboratory findings of each of these three kidney injuries. Now we'll talk about the prerenal azotemia, which is due to the hypovolemia, which leads to the decreased cardiac output and the decreased effective circulating volume, example heart failure and the liver failure. Pathophysiology, decreased renal blood flow, which leads to the decreased glomerular filtration rate, and which leads to the increased reabsorption of the sodium and water and urea. Laboratory findings: urine osmolarity are greater than 500. So, sodium in urine are less than 20. Fractional sodium excretion is less than 1%, and serum blood urea nitrogen creatine ratio is greater than 20. Now we'll talk about the intrinsic renal failure, which can occur in tubule and the interstitium, in glomerulus, in vascula. For tubular and interstitium, acute renal necrosis, example ischemia and nephrotoxins, acute interstitial nephritis. For glomerulus, acute glomerulonephritis, vasculitis, malignant hypertension, and thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. In acute tubular necrosis, pachynephrosis leads to debris obstructing tubules and fluid backflow, which leads to the decreased glomerular blood glomerular filtration rate. Now we'll talk about the laboratory findings are: the urine osmolarity is less than 350, sodium excretion in urine is greater than 40, fractional sodium excretion is greater than 2%, and serum burn by creatine level is less than 15. Postrenal azotemia, it can be caused by stones, benign prostatic hyperplasia, neoplasm, and congenital anomalies. Its pathophysiology outflow obstruction, it could be bilateral, and all laboratory findings are varies. Acute interstitial nephritis it is also known as tubulointerstitial nephritis. Acute interstitial renal inflammation, polyuria, classically eosinophils, and azotemia occurring after administration of drugs that act as heptans, including hypersensitivity, example diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, quinolones, and sulfonamides. You can remember these drugs by remembering 5 P's, 5 Ps, 5 P's. P for diuretics, as you can see here, pain-free for NSAIDs, P for penicillin and cephalosporin, P for proton pump inhibitors, rifampin, and sulfa drugs. Yes, for sulfa drugs. Less commonly may be secondary to other processes such as systemic infections caused by mycoplasma or autoimmune diseases, Sjogren syndrome or SLE, sarcoidosis associated with fever, rash, polyuria, hematuria, and costovertebral anger tenderness, but can be asymptomatic. Renal osteodystrophy, hypocalcemia, hyperphosphatemia, and renal failure of vitamin D hydroxylation associated with chronic kidney disease. It leads to the secondary hyperthyroidism, which leads to tertiary hyperthyroidism if secondary is poorly managed. High serum phosphate can bind to the calcium ion, which leads to the tissue deposits of calcium, which leads to the low level of serum calcium and low level of 125 dihydroxy D3, which is also known as calcitriol, which leads to the decreased interstitial calcium absorption, causes subperiosteal thinning of bones. Acute tubular necrosis, it is the most common cause of acute kidney injury in hospitalized patients. Spontaneously resolve in many cases. It spontaneously resolves in many cases. Can be fatal, especially during initial oliguric phase. Increases fractional excretion of sodium. In this disease, key findings are granular casts, often muddy brown appearance. As you can see in this image, it's a granular cast with a muddy brown appearance. These are the muddy brown appearance. It's shown in the acute tubular necrosis. There are 3 stages of disease. First one is the inciting event. Second is the maintenance phase. Third one is the recovery phase. In maintenance phase, it could be oliguric, last 1 to 3 weeks, risks of hyperkalemia, metabolic acidosis, and uremia. In recovery phase, it's polyuric, blood urea nitrogen and serum creatine ratio can be fall. risks of hypokalemia and renal wasting of other electrolytes and minerals. It can be caused by ischemia or nephrotoxic injury. First, we'll talk about the ischemic, secondary to the low renal blood flow. Examples: prerenal azotemia, resulting in death of the tubular cells that may sludge into tubular lumen. As you can see in this image, here we can see the sludge of the tubular lumen. That means it is constricting. It's getting constricted. Proximal tubules and thick ascending limbs are highly susceptible to this injury. Remember this: proximal tubules and thick ascending limbs are highly susceptible to ischemic injury. Now we'll talk about the nephrotoxic. It is secondary to the injury resulting from toxic substances such as aminoglycosides, radiocontrast agent, lead, cisplatin, ethyl glycol, myoglobinuria, rhabdomyolysis, hemoglobinuria. Proximal tubules are particularly more susceptible to this injury. Remember this: proximal tubules are particularly susceptible to this injury. Diffuse cortical necrosis. Acute generalized cortical infarction of both kidneys, likely due to a combination of vasospasm and DIC. Acute generalized cortical infarction of both kidneys, likely due to a combination of vasospasm and disseminated intravascular coagulation, associated with the obstetric catastrophes. Associated with the obstetric catastrophe. Example: placental abruption and septic shocks. Renal papillary necrosis. Sludging of necrotic renal papilla, as you can see here. Sludging of the necrotic renal papilla, which leads to the gross hematuria, may be triggered by recent infection or immune stimulus, which is associated with the sickle cell disease or trade, acute pyelonephritis, analgesics like NSAIDs, diabetes mellitus. You can remember it by a mnemonic: sad papa with papillary necrosis. Sad papa with the papillary necrosis means S for sickle cell disease trade, A for acute pyelonephritis, A for analgesic, which includes NSAIDs, D for diabetes mellitus. It are the associations of the papillary necrosis. So remember, sad papa with papillary necrosis. Now we'll talk about consequences of renal failures. Decline in renal filtration can lead to excess retained nitrogenous waste product and electrolyte disturbances. Consequences: you can remember consequences by a mnemonic: mad hunger, MAD, mad, HUNGER, mad hunger. All these letters shows the consequences of renal failure. M for metabolic acidosis, D for dyslipidemia, especially increased triglyceride, H for high potassium, U for uremia, N for sodium water retention, which leads to heart failure, pulmonary edema, and hypertension. G for growth retardation and developmental delay. E for erythropoietin deficiency, which leads to the anemia. Renal osteodystrophy. There are two forms of renal failure, which includes acute and chronic. For acute, it's acute tubular necrosis, and for chronic, it's hypertension, diabetes mellitus, congenital anomalies. Incremental reduction in the GFR defines the stages of chronic kidney diseases. Normal phosphate level are maintained during early CKDs due to increased level of fibroblast growth factor 23, which promotes renal excretion of phosphate. Uremia. It is a syndrome resulting from high serum urea, can present with pericarditis, encephalopathy, anorexia, and nausea. You can remember it by a mnemonic European, which sounds like a European. European, Uri for urea, P for pericarditis, E for encephalopathy, A for anorexia, and N for nausea. So European sounds like a European. Renal cyst disorders. First we'll see autosomal dominant polycystic kidney disease. Numerous cysts in cortex and medulla causing bilateral enlarged kidney ultimately destroy kidney parenchyma, present with combination of the flank pain, hematuria, hypertension, urinary infection, progressive renal failure in approximately 50% of individuals. It caused due to mutation in PKD1 gene and PKD2 gene. PKD1 gene encoding for a polycystic protein, approximately 80% of cases on chromosome 16. PKD2, 15% of cases on chromosome 4. Complication includes chronic kidney disease, hypertension caused by increased renin production associated with berry aneurysms, mitral valve prolapse, benign hepatic cyst, and diverticulosis. Treatment include if hypertension and proteinuria develops, treat with ACE inhibitors and ARBs inhibitors. Second is the autosomal recessive polycystic disease. It is caused by mutation in PKHD1 gene, which is encoding for fibrocystin. Remember that autosomal dominant polycystic kidney disease caused mutation in PKHD1, which is encoding for polycystin protein, and autosomal recessive polycystic disease caused due to mutation in PKHD1, which is encoding for fibrocystin. Got it? Now, cystic dilation of collecting ducts often presents in infancy associated with a congenital hepatic fibrosis. Significant oliguric renal failure in utero can lead to a Porter sequence. Concern beyond neonatal period includes systemic hypertension, progressive renal insufficiency, and portal hypertension from congenital hepatic fibrosis. As you can see in this image, there are numerous cysts. You can see there are numerous cysts in cortex and medulla, in, as it's showing the autosomal dominant polycystic kidney disease, as it has numerous cysts present here. It's showing in cortex and medulla. In this image, you can see a cystic dilation of collecting duct, as it's shown in a autosomal recessive polycystic kidney disease. Now we'll see the autosomal dominant tubulointerstitial kidney disease. It is also known as medullary cystic kidney disease, which caused by causes of tubulointerstitial fibrosis and progressive renal insufficiency with inability to concentrate urine. Medullary cyst, usually not visualized, smaller kidneys on ultrasound. It has poor prognosis. Now, simple versus complex renal cyst. First we'll talk about the simple cyst, then we'll talk about the complex cyst. Simple cysts are filled with ultrafiltrate, as you can see here in this image, which is known as anechoic on ultrasound. Simple cysts are filled with ultrafiltrate, which known as anechoic, as you can see in this image. It is ultrafiltrate showing on ultrasound. It is very common and account for a majority of all renal masses found incidentally and typically asymptomatic. Complex cysts including those that are septated, enhanced, or have solid components on imaging, requires follow-up or removal due to a possibility of renal cell carcinoma. As I mentioned earlier, simple cysts have ultrafiltrate, anechoic on ultrasound, and complex cysts have solid components on imaging. Renovascular disease. It includes unilateral or bilateral renal artery stenosis. Renal artery stenosis leads to decreased renal perfusion, increased renin, increased angiotensin, which leads to the hypertension. It is most common cause of the secondary hypertension in adults. Main causes of the renal artery stenosis are atherosclerotic plaque and fibromuscular dysplasia. Atherosclerotic plaque in a proximal one-third of renal artery, as shown here. It is the proximal one-third of the renal artery. Usually occurs in older males and smoker. Second cause is the fibromuscular dysplasia in distal two-third of the renal artery or segmental branches, as shown here. It usually occurs in young or middle-aged females. For unilateral RAS, means there is a defect in only one kidney. Affected kidney can atrophy means it loses cells, which leads to asymmetric kidney size. Renal venous sampling will show increased renin in affected kidney and normal renin or low renin in unaffected kidney. For bilateral RAS, means both kidneys are affected. Patient can have a sudden rise in creatine after starting an ACE inhibitors or and ARB or renin inhibitors due to their interference on renin-angiotensin-aldosterone system-mediated renal perfusion. It can be present with the severe refractory hypertension, flash pulmonary edema, epigastric flank bleed. Also, patient with RAS may also have a stenosis in other large vessels also. So now we'll try to understand the renal artery stenosis by this image showing here. So its causes are atherosclerotic plug in a proximal one third of the renal artery, or a fibromuscular dysplasia in a distal two third of the renal artery or the segmental branches. So after that, the kidney is getting ischemic, so it releases renin. That means it increases renin, which converts angiotensinogen to angiotensin 1, which after converting to angiotensin 2, which have three effects as shown here. It first acts on a suprarenal gland, which produces aldosterone, which increases sodium retention, ultimately cause hypertension. Thus, secondly, it acts on a it increases sodium retention, ultimately cause hypertension. And thirdly, it acts as a vasoconstriction, so it will increase hypertension. Renal cell carcinoma. It shows polygonal clear cells as showing in this figure. Is showing a polygonal clear cells filled with accumulated lipids and carbohydrate, often golden yellow due to increased lipid content as showing in this figure. It says like a golden yellow. It's due to increased lipid content inside that. Originated from PCT, proximal convoluted tubule, which invade into renal vein, which after that going into the inferior vena cava, which leads to the hematogenous spread, and it leads to metastasis to lung and bone. Firstly, the renal cell carcinoma originated from a PCT, proximal convoluted tubule, which invades to the renal veins. After that, vena cava, then the hematogenous spread of that carcinoma takes place. It metastasis to the lung and bone. Its manifestation associated with the flank pain, palpable mass, hematuria, as well as anemia and secondary polycythemia, which is less common. Also, there is fever, weight loss. The treatment includes surgery, ablation for localized disease. Treatment includes surgery, ablation for localized disease, immunotherapy with ipilimumab, or targeted therapy for metastatic disease, rarely curative, resistant to the radiation and chemotherapy. It is the most common primary renal malignancy, as you can see in this image. The renal cell carcinoma is the primary renal. It's most common primary renal malignancy, most common in males 50 to 70 years old. Increased incidence with tobacco smoking and obesity associated with the paraneoplastic syndromes. Example: parathyroid hormone related proteins, ectopic erythropoietin, adrenocorticotropic hormone, and renin. You can remember it by mnemonic PEAR. P for parathyroid hormone related protein, E for ectopic erythropoietin, A for adrenocorticotropic hormone, and R for renin, which are aneoplastic. Clear cell, most common subtype associated with gene gene deletion on chromosome 3, which is sporadic or inherited as von Hippel-Lindau syndrome. You can remember it by a mnemonic or mnemonic by 3 letters like RCC, which is a renal cell carcinoma, have 3 letters. And affected, the deletion, the the gene deletion occurs on a chromosome number 3, as you can see here, and which is associated with the VHL, which is also 3 letters. VHL means von Hippel-Lindau. So you can say that in renal cell carcinoma there is a deletion, gene deletion on chromosome number 3, which is associated with the von Hippel-Lindau syndrome. Both have 3 letters: RCC, chromosome 3, and VCL. Got it? Renal oncocytoma. So it is a benign epithelial cell tumor arising from collecting ducts. As you can see in this image, the arrows pointing to well circumscribed mass with a central scar. In this image you can see a clear cut difference between an oncocytoma and a background tubules. In this side of image you can see a large eosinophilic cells with abundant mitochondria without perinuclear clearing. In this side of image you can see a chromophobe renal cell carcinoma. Renal oncocytoma presents with a painless hematuria, flank pain, abdominal mass. Often it is often resected to exclude malignancy. Example: renal cell carcinoma. Second is the nephroblastoma. It is also known as Wilms tumor. It is most common renal malignancy of early childhood in ages 2 to 4 years old childhood. It contains embryonic glomerular structures, most often present with a large palpable unilateral flank mass, as you can see in this image. Here I am highlighting, and hematuria and possible hypertension. It can be associated with a loss of function mutation of tumor suppressor gene, which is WT1 or WT2, which is present on chromosome number 11. You can remember it by Wilms itself, as you spell Wilms WILMS. So IL, you can remember it like a 11. So what is nephroblastoma? Nephroblastoma, it is it is just it is just a mutation mutation in the tumor suppressor genes WT1 WT2, which is present on chromosome number 11. It may be associated with several syndromes like Weiger complex, W for Wilms tumor, A for aniridia, which means the absence of the iris, G for genitourinary malformation, R for range of the developmental delay, which is caused because which is caused due to the deletion in gene WT1, which is present on chromosome number 11. Second one is the Danes-Drash syndrome, which is also part of the Wilms tumor. Firstly, for diffuse mesangial sclerosis, which is early onset nephrotic syndrome, and secondly represents dysgenesis of gonads, which is male pseudohermaphroditism, which is caused by a mutation in WT1 gene. Both W1 Weiger complex and Danes-Drash syndrome caused just because mutation in a WT1 gene. Now third one is the Beckwith-Wiedemann syndrome. It is also part of the Wilms tumor. It associates with microglossia, organomegaly, hemihyperplasia, imprinting defect causing genetic overexpression of associated with the WT2 gene. It is only associated with the WT2 gene. Now I'll talk about the urothelial carcinoma of the bladder, which is also known as the transitional cell carcinoma. It is most common tumor of the urinary tract system. Can occur in renal calyxes, renal pelvis, ureters, and bladder. As you can see in this image, it shows the transitional cell carcinoma, and in this image you can see the microscopic changes in a transitional cell carcinoma as it presents a fibrovascular core in papillary tumor and dysplastic urothelium instead of the transitional urothelium. Please do remember this: fibrovascular core and dysplastic urothelium. Can be suggested by a painful hematuria with no cast associated with problems in your P-sac. P-sac is the mnemonic for its remembering its association, like phenacetin, which is a drug, tobacco, smoking, aromatin, amines, found in dyes, and cyclophosphamide. P for phenacetin, S for smoking, A for aromatic, and C for cyclophosphamide. Now we'll talk about the squamous cell carcinoma of the bladder. It is a chronic irritation of the urinary bladder which leads to the squamous metaplasia, which again leads to the dysplasia and squamous cell carcinoma. Risk factors for this disease occurring includes 4As. 4As. It is mnemonic to remember its risk factors, such as cystosoma, hematobium infection in Middle East, chronic cystitis, cis, So first one is the cystosoma, second one is the cystitis, as you can see here. Third one is the smoking, And the fourth one is the chronic nephrolithiasis, which is also known as stone. So fourth one is the stone. It is present with a painful hematuria with no cost. Please remember. Here we end with the pathology of the urinary system. The next video will be on the pharmacology of the urinary system. Thanks for watching. Like, share and subscribe to my channel.